is building. Lift your voice and worship Him. He's the awesome God, the soon coming King, the Alpha and the Omega. Lift your voice, everybody. Yeah, yeah, yeah. Awesome God you are. Awesome God you are. Awesome God you are. A binti so. Awesome God you are. Awesome God you are. Awesome God you are. Oh binti so. Everybody say. Tell Him how awesome He is in every season. He alone is worthy. Tell Him how awesome. Oh, oh, awesome God. The beat. Tell Him, say mighty. You are mighty God. You are mighty God. Oh, Jesus, oh, tell Him mighty God. Nyamika kraka, nyamika kraka, nyamika tinka. your voice in this room and say, Father, worship to you when we have no words to say. Oh,
when we have no words to sing, we cry out and say, oh,
we cry out. Oh, sing it again, sir. My worship, I give it all to you. Thank you, Jesus.
Good evening, everybody, and welcome to your favorite show. The Inside View here with Nana Hagen, and I hope you've all had a wonderful Sunday, and you are all, well rested and looking forward to a brand new week. Today we are going to have a difficult, conversation that we, don't talk about in our families because we think, we should just wait for nature to actually take its natural course. But that's why we have the inside view. We talk about topics that nobody wants to discuss. Nobody wants to even think about them. And this topic tonight, it's quite sensitive, but I just want everybody to just lend me maybe an hour of your time to listen to this conversation, so that we'll not just be taken by surprise. And we also say that knowledge is wealth. So I have with me a beautiful young woman who is so much passionate about this area of conversation. Tonight we're talking about palliative care and also end of life matters, and we just going to explore what at all it is. And to help me do that, I have with me Effe Adjei, who is a registered nurse and also an entrepreneur here in the UK. So let's welcome Effe Adjei. Effe, how are you?
I'm all right, thank you, Nana. How are you too?
I'm good as well. And how's been your day?
Oh, good. It's been a lovely day here in Welling Hall. A little bit of rain, but overall, it's been a nice day. And yeah, looking forward to this very difficult conversation that needs to be heard. So yeah.
Wow. Many of my guests, do not know you, and for the sake of my new viewers, and also for your sake of people who have never met you before, we just want to know who Effe Adjei is, a little bit, about your background, the kind of family that you grew up in, that has shaped the kind of beautiful woman that you are today. So just take it up.
Okay. So my name is Effe Adjei. Hello, everyone. And I am originally from Ghana, born and bred in Tema, and lived there for a while. Went to school in St. Paul's, went to Adjei SS for a while, for 3 years, and then went to Abrigel. So I'm a proud Abrigel chick.
Ooh.
And yeah, after Abrigel's, I worked in Tema Women's Hospital for a while because I was very passionate about nursing. I grew up as an only child, and I had an aunt that worked in airport clinic. So as part of good behavior, my mom would take me to see my Aunt Teresa in airport clinic. So it was something that I looked forward to. She was a medical assistant at the time. So she was a nurse before she went all the way up. It was such a pleasure to go to airport clinic and see her. And I grew up aspiring to be my Aunt Teresa, the nurse. In the little area that we lived in Tema Community 8. I would nurse everybody and everyone. All you had to do is have a bit of a sore, and I'm there looking after you. So I've been really passionate about caring for people. And when I traveled to Dublin, unfortunately, it was very hard to get into nursing at the time, and I went back to school. My first degree was in social studies, where I studied to work with children and adults with autism. So that was quite a difficult area, but it was a real eye opener. After my degree, I got a job in Piedmont Hospital as a social care worker. And it was the first time we were piloting, integrating people who have been institutionalized into the community. So I was part of the few social care workers that were recruited at the time. I also worked for Guild Autism Services, and I totally enjoyed my time there. I worked there till I came to UK. Upon getting here, social care was not recognized as it was in Ireland, So for here, it was a support worker. So it was totally different. Anybody could be a support worker. You just had a bit of training, and I felt I was losing myself. So I went back to University of Wolverhampton, where I graduated as a general nurse, and I've carried on since. My nursing career started off as a theatre nurse. So I did a scrub nurse. I was a scrub nurse for a while. And then after my scrub, I went to do dialysis. I went into community as well and worked out of hours. I worked for the Walsall Manor Hospital and MPFT out of hours. I totally enjoyed my time there. And that was when I came into contact with a lot of palliative patients, doing advanced care plan, looking after people and their families, the whole holistic care. And in between, I would lose my mom. So that was a very difficult time for me. And when I was working as a palliative nurse and dialysis nurse, my uncle got very, very sick. And that was a life changer. And I saw the palliative struggle in Ghana, that there was none. There was no recognition, there was no pathway, there was no care plans. People were just left. And it gave me a bit of headache and annoyed. I've got a few doctor friends. I spoke to them. I tried to organize this. There's a whole lot of legislation in Ghana that is not seeing real sick people who are dying. We don't want to recognize palliative as part of life. We don't want to recognize end of life. We think hospital is the best place to be. And it's quite heartbreaking. So I thought we'll do something different, So in 2029, I set up my own company where I worked on it as an agency nurse.
I'm sorry to interject, but I think we'll get to that point because
Okay.
I just want us to build to that point. You know what I mean? So let us slow down on the employment part, and then we just zoom into that a bit later. I could tell that you've got a vast years of experience in the area of nursing. I mean, you've been, a child's nurse, like children's nurse, sorry. You've been autistic nurse as well. I mean, you've looked after, autistic patients and many more. And are you being emotional, or
Oh no, it's just I'm fine.
Are you sure?
Yeah.
Okay. I just want to make sure that you're fine because
Yes, I am.
Okay, that's fine. I've seen you talking about nursing in Ghana, and also you being a nurse here. What is it like, being a nurse in Ghana?
I've never nursed in Ghana. I haven't had the license to nurse in Ghana, but I have a lot of friends that owns their own hospitals and clinics and who are doctors running this place. And I've shared their frustration. I've done a bit of forums with them, talking to them about the daily challenges that they face, because what I wanted to do was set up some form of practice that could see palliative patient being cared for in a holistic manner. So I did an extensive work with my friends that were doctors and a few nurses who ran their own clinic and hospitals. So I came across a lot of challenges and a lot of cultural backgrounds and a lot of cultural blocks, religion blocks, everything in between except caring for the patient. So we've got all these heights, and the only thing that we haven't got protected is the patient's itself. So that was one of my frustrations in Ghana, in seeing the whole holistic view of caring for people who are dying.
Okay. I mean, if I'm getting you right, like, is it because we don't even understand what palliative is all about? If so,
Exactly.
could you please educate us on what palliative care and also what end of life, I mean, is all about? Um,
Okay. So, palliative is when you are actually relieving pain without dealing with the cause of condition. So, a typical example is somebody diagnosed with cancer, maybe stage one, stage two, stage three, is treatable. They are doing everything to make sure this patient has a bit of quality of life and treating this patient. Patient is responding to treatment, they are doing well. Patient has had operation, say something colorectal, so they've had hemicolectomy, or they've got some bowels taken and the cancer is taken out. 5 years down the line, cancer comes back and they have a bit of metastasis, which means that the cancer has spread to other places unknowing to the patient. They haven't been symptomatic prior to that. And then all of a sudden, they get really, really sick. And doctors realize that the secondary cancer is all over the place. So the primary would have been the bowel one, or whatever they came in with in the beginning, or the source of the cancer from the beginning. And then the secondary is when it's completely spread everywhere and it's everywhere else, lungs everywhere. When this happens, they will try and do a bit of chemo to slow it down. They will try everything possible to save life, because that's what we hear for as nurses and medical practitioners. Our aim and our ethics is saving lives. Basically, that's our first priority. But when that has failed, when your body has not responded, when um, every intervention has not been successful, we don't want to say, okay, you know what, because medication has not worked for you, that's it, goodbye. There has to be some kind of continuity. And that continuity is what it's palliative. So from that time onwards, you're being treated for the symptoms. So if the cancer has spread everywhere and, medication has not worked and everything like that, if you have a bit of cold, we will not say that, oh, you know what, because you've got cancer and we can't treat it, you know what, goodbye, or we will not treat your cold. No, we will treat the cold. If you have got metastasis and you are not responding to treatment and your eyesight is bad and you used to love reading, you will have your eyes checked and it will be looked after. If you fell out of bed and broke your leg or something, you will still undergo treatment for that. Because, mind you, that is not primary. That is not part of the reason why they've stopped treatment. That is treatable. The broken leg is treatable. The broken arm is treatable. The wound care is treatable. If you had a wound, the cold is treatable. So every other thing, apart from the primary thing that you're dying from, will be treated. So that's a holistic view of palliative care. Along the line, let's say 6 months from that, a year from that, or 2 years, you can be palliative for 5 years. Along the line, when your body now start giving in, not responding to treatment, not responding to your symptoms are overcome, or you are overwhelmed by your symptoms. So basically, your symptoms are not even managed properly or cannot be managed anymore. So you're just going down because it's just time for you to go. Then you become end of life, and it's recognizable for some people, and for some people it's not. So depending, and mind you, sometimes we can get it wrong. Somebody could be end of life and they could be here for another 10 weeks, 12 weeks. So depending, some people just can just pick up. So you will be nursed in a properly and ethically until the very last day. So you don't really classify somebody as palliative, end of life, this, that, and put them in boxes and not look after them. No, that's not what this is all about. This is about recognizing it and putting in contingency plan, interventions, therapeutic approach into the whole holistic view of your life coming to an end, sort of, and putting in that gives us an opportunity to work with you over here as a community district nurse. We will come to your house. We will do advanced care plan if you haven't got one. We will look at DNAR. That's would you like to be resuscitated or not? We will have a lot of heavy conversations with you and your family to see what you want to do in the end. So when you are palliative for that long, you kind of privileged to put a lot of things in place when it gets to the end. And that is what sometimes we're missing, because you have a lot of opportunity then, or you don't even have to be palliative, but you can still have this conversation, put things in place, because most of the time when things like this happen, it kind of happen very fast and you go downhill very fast without any form of warning. Something like dementia, when it's coming on, people may recognize, people may not recognize. By the time that it's really, really obvious you fully, into a phase that you can't make decision for yourself. So then we can't even get you to make decision for yourself, or get you to do an advanced care plan, or get you to have power of attorney for somebody, or like hope somebody. You can't choose your next of kin anymore. You can have somebody to do your power of attorney, because now you've got dementia, that you are not compos mentis, and you have everything now has to be done for you in best interest. So it's better for everyone to have this conversation now, put things in place before things kind of deteriorate.
Wonderful. So, when you felt so frustrated, especially when you realized that your auntie, your mom, and also your dad, could not receive the right treatment. I mean, in your estimation, um, do you think, as people, we do not understand what palliative care is all about, or we just don't care, we just don't accept that, there's something, that we can just give a relief to patients who are in this condition. What was your thing that you draw from all the frustrations that you went through?
Okay. With my mom, I was a bit privileged because I left Dublin for 8 weeks to be with her, and she died the day before I was meant to come back. So that was a good thing for me, that I was there till the end. I didn't want to miss any of this. I think it would have broken me more if I had had the phone call that she was no more here. She never left me anywhere. So I never wanted to leave her anywhere. So with my mom, I was privileged to be with her. So there are things that people want, and there are things that scares people. And there are things that people caring for people who are dying haven't got the clue, or the knowledge, or the ability to comprehend. Today, I am appealing that people listening, if you don't take anything at all from this, please remember that you are acting for somebody. If somebody is dying and they haven't got capability to make decision for themselves, it's not what you want. It's not about you. It's not about what will look good for you. It's not about what people will say about you. It's all about that person in that bed dying. Make it worthwhile. I mean, I don't know if we'll ever get an opportunity to do a survey about, people who have passed on, to tell us how their experience was, or how they felt when they were dying. So far, nobody has ever done that research or survey before, because we just can't. So if anybody is going to pass away and you know it, and you feel it, or you've been told by doctors that, there's nothing we can do about this person, spend quality time with them. Make memories with them. Forget about you and make it about them. That's all I'm asking from all of this, that, just make it about them. They won't come back to say, you did well, you didn't. They won't come back to say, you know what, I would have preferred it this way. But just take the person's personality, what makes them lived, what they enjoyed. Don't rob them of the last things, or the things that matters to them. Sometimes you have some family members and some dynamics that, when somebody's a little bit sick, we keep them in rooms, we lock them up, Family members are not allowed to visit. We don't want anybody to know they are sick. Why? It's not a communicable disease. If you're dying from diabetes, kidney failure, hypertensive, that has not been treated for a long time, cancer, it's not transferable. People need to sit with you. People need to be with you. It actually projects, like research has shown that people that are surrounded by their family members, they kind of live a bit longer in their palliative and end of life states, because they're surrounded by love. And I feel, in my experience, dying is a very lonely journey. You are the only one going to take this journey. No matter the amount of people surrounded by you, they can't go with you. They can't help you. They can't do anything about it. And you are just lying there. The last thing you would want is somebody making decisions to prevent everybody from coming around you. Imagine, how would you feel? I am a people's person. I love my Presec Ebugi's platform. I like to have fun there. I've got a few good friends and things like that. I want them around. If I'm dying, I want them around. If I'm dying, I want to be in a monochrome. I want to be on the mountains. I want to a rented hotel playing Bon Jovi, and I want my people there. Imagine if you said, no, you're dying, it's scary. So I'm going to leave you here on your own and you do this by yourself.
Wow.
Why?
Effe, I could tell that you're just a people's person, and also you've just got a good heart to look after people. Um, I could just feel your passion. I could just feel your passion. And to anyone watching us, if a wants to provide employment for anybody that wants to work in the health sector, she will train and also offer you a job. So if you're listening to us and you want a job, or like if you want to work in the health sector, please, after this interview, you can contact me, you can DM me, or you can look for Effe Adjei on Facebook and just link up. I think maybe I should be able to provide you more information, more than maybe I can do. But please, if any of you is interested in working in the health sector, please, she's the your entrepreneur over there. Please contact her, and I hope she'll be of a great help to you. So please share this conversation. Share this conversation, and let this conversation go far. This is a very, very difficult conversation that we don't even want to even think about. So please, if anyone is declared, palliative, I mean, if it's right to say, that person is still a human being,
Of course.
and deserves, good treatment. Deserves to be looked after well. Everything that matters to life, should also be given to that person.
Of course.
Yeah. Okay. I think most of us do not even know the difference between palliative and hospice. You can, just talk to us about palliative care and also hospice care.
Okay.
I mean, what
So
that means.
the hospice is where you go to if you choose to. Not like some people will say, okay, you know what, I want to die in a hotel for some reason. I just want a hotel on a mountain overlooking the valleys with the light of um Accra, because I'm just a village girl and that's what I want. So for some people, it's scary for the family. The family are struggling because in as much as we want positive things for the person dying, sometimes they also think about the family they are leaving behind. And the last thing they want is to impose on them. So you could have a family that everybody is working, they're meant to work to help this person, and they've got to care for this person as well. So in the palliative state, or when it's getting to a bit of end of life, they may choose to go to a hospice where they could be and die there, So it's not euthanasia, please. I'm not preaching death or anything like that. No, it's none of that. It's just a place that it offers solemn. They've got people who are trained and understand the whole process, where you could, your wishes and how you would want things to be, what you would want. If you would like to, sometimes palliative patients will go to hospices and they could do a memory box for their children. So what did their children went through, or the people that they've encountered and their life history, or a little bit, write something about themselves before the final day happens. And when you're in hospice, it means that district nurses are not coming to your home every day. And some people, it's just them, they haven't got much family to help them in that state. So, or maybe family is living somewhere abroad and things like that. So the hospice will provide a holistic care. They do have doctors round, they have nurse practitioners, they have palliative link nurses who come and look after people there. And during palliative and end of life state, end of life state as well, people will go through things, certain stages that needs a nursing input. So when you're in a hospice, then you are privileged because you've got a nurse right there, rather than when you are at home, which is also good because I've worked on the district nurse out of hours. If you call us, we aim to be there for about 20 minutes, maximum. We do an hour call. Within the hour call, if we don't get to you by the hour, then you need to report it and say something. But most of the time we do aim to get to you by the hour if you're palliative, especially if you're going through the 3 symptoms that we will look out for, that we don't want you to go through. That's pain, agitation, and some nausea. So if you're feeling any of these 3 things that's associated with end of life, if you call the district nurses, we aim to be there within the hour to make sure that, like I said, you won't come back to let us know how well we did or how well we didn't or what we need to change. So whilst you are with us, we aim to make everything gold standard. So yeah.
Great. And so, like in your estimation, what can countries do? Like a typical, like a case study. So okay, like we use Ghana as an example. What can a country, like Ghana, do to include, palliative care in the continuum of care for people with chronic and life-threatening conditions, linking to prevention, early detection, and treatment programs?
I hope the Minister of Health is not listening to this because I've got to say this. Ghana, our health system is shocking. We really, really need to sit down and do a lot, because a lot of people are falling through. I understand the religious background and our faith and everything. I can't take that from anybody. I can't ask somebody to stop feeling some way or stop worshiping a God or anything like that. But all I want to say is when you get to that stage, incorporate your faith. In as much as you're doing all this, please, can our system support and allow things to go through the natural process? It's not, it's like some people will even have the light off, or our health system will not recognize this. You've got a 98-year-old woman who is like, dying from frailty. You could tell, they've become symptomatic a little bit. Things are not working right. You've done bloods, you've done this, and then you come out and say, okay, you know what? They've got pneumonia. Okay, so I mean, how are you going to treat this pneumonia? This patient is actually dying. So you send the patient for MRI, you do scan, you do this, you do. What do you aim to treat? Why are you not providing palliative care for this patient? Why are you not giving the family the opportunity to take her home and nurse her? Why are you not giving them the opportunity to spend time, the little time that they have? They're now going to shuffle up and down, looking for this medication, looking for that medication, staying in queues, doing this, doing that. And at the end of the day, by the time they get all these things together, the person is dead. And that's what annoys me because you, the medical practitioner, based on the bloods, based on the things that you've done, where this is going. All you need to do is sit down with the family, have this conversation with them. The hospital is there for them to assess if any other thing develops that needs treating. But from the primary thing that this person is dying from, that there's no treatment that the body is responding to, Why can't we nurse this person at home? Have proper care plans in place. You know, if this happened, this is what you need to do. If that happened, this is what you need to do. And spend time, because the hospital is the last place you want to be when your immune system is compromised. The hospital is where you pick up all the nasty things that ever the world ever offered, you know. So I don't understand why we encourage people, why we can't integrate the community care into our system, you know. Everywhere in Ghana you'll have a maternity home, you know, you'll have a medical practitioner who has worked somewhere before and is now practicing. They can recognize all these things. They could have a registered nurse in place who can develop care plans, add the whole family together, have this conversation, make sure bed sores are prevented, make sure this patient is eating, the family will be able to look after the patient more than the nurses in those places. The
Definitely.
family
Yeah.
understand it, then it becomes an individualized care rather than throwing them in the hospital and God only knows what's happening to them. You know, if they say they don't want to drink, that's it. No, everybody leaves them. It's not documented, they are not supported, nothing is happening. You take your patient to your loved one to the hospital for 3 days and they've got a grade two bed sore. Why would I do that?
Do you even think, we have this patient nurse relationship or patient, doctor relationship, status? I don't even think people can even go to the hospitals and really, feel comfortable, explaining the symptoms. You know, to the doctor, sometimes even before you finish talking, the doctor has even, actually just prescribed or just giving you your prescription. And sometimes you just ask yourself, you didn't even allow me to finish, talking. And you just handed me, my prescription. What shows that, I don't understand. So I just want to ask, is it because, as a society, I don't know. I mean, you are the next. I mean, oh, I'm just getting a bit emotional because
Yeah.
my father, died as well, in a situation where, when you talk to nurses or doctors, it's as if they don't even want to listen to what you're saying. Sometimes it can be a bit frustrating. It can be very, very frustrating. Yeah. So
So
yeah.
the good thing is I've asked a few of my doctor friends to listen into this, so
Mm-hmm.
I hope they listen. They have absolutely no social skills, all of them,
That's
including the ones that I know very well.
wow.
Their social skills is shocking. All most of my doctor friends, I have to be honest.
Apart from the
Uh,
social skills too, I think some of them it's also due
yeah,
to arrogance. Most of them are too arrogant. Very, very arrogant.
because we worship them. But what they forgot is the patient care. It's my body. Okay, if I come to your clinic and you order some bloods and I go and do the blood, it's my blood. I even paid for it. So when I finish, I expect you to go through every one of them. Tell me why you did this blood test and what you were looking for and how is my results responding. That's what I would expect for the money I've paid for. Okay. If I come to Kolebu or whatever, if the government is paying you, if you don't feel up to it, don't come to work. I would rather we have two doctors working for patient than 100 doctors that patient can't access. You know, I had huge problems in Ridge Hospital. I mention them everywhere I go. You know, to the extent that in my mom's private room, I did everything for my mom because what they were doing is when doctors were coming round, they were saying, oh, her input was 1,500 and her output was 1,200. So she's doing well. No, she's not. I gave her the water. All she had was 1 liter all day. I documented it. She's only paid 200 mils. That's not good. She is still retaining. So where did you get these records from? And I challenged them. And because I challenged them, nobody came to see my mom.
Yeah.
Nobody wanted to nurse my mom. But I wasn't having any of this. You know, it was bad practice. I would say I say it everywhere, and I was so glad when this I asked when they said they were discharging her. I was so glad, and she said, "I know she'll be next better at home," and I totally agreed. And we brought her home. She wanted to come home anyway. One day when they were doing catheterization, which is ANT&T, it's supposed to be a sterile thing. After she's changed gloves and everything, somebody called her and she put her sterile gloves in her pocket. And when she finished, she was very confident. She touched the catheter, about to recatheterize. And I said, "No, you're not doing that." Imagine if that was you. This is an invasive procedure. So what you're doing is somebody who is already compromised, suffering, you are now going to introduce another form of infection that her body is not even able to fight. So our doctors and our nurses, I know you're overwhelmed with work. So is everybody else. I haven't seen any professional or anybody in their profession that says, "You know what, I haven't got any stress," or "It's an easy peasy job." Everybody, one way or the other, struggles in their workplace. This is something you're doing for another person's family member. It may be a daily thing to you, it may be a passive thing to you, but it's personal to us. I've got the memories. I hold on to it. I'm bearing you grudges. I'm not letting it go. I am angry because this is my mother. And so is everybody or every patient that you come across. If we want to speak to you, especially those in abroad, if they're so worried and they just want to speak to the doctor, it's like near to impossible. Why?
Yeah. So, Effe, for you, what are the significant benefits apart from religion um, that needs to be overcome, like in order to address the unmet needs for palliative care?
It's our attitude towards healthcare. We don't care about our own health. We don't care about things that are happening to us. And the people we put in charge to look after us are showing the same attitude. So if you don't care to follow up your lab results, if you don't care to follow up with the doctor, if you don't care enough to look for a primary doctor to look after your father, and you're taking them to the big, big hospitals where you can't access the doctors, why should they care about your person? We need to make serious changes. We need to start looking into primary healthcare, personal doctors, personal nurses, personal healthcare assistants who've got the knowledge and the background to nurse people home safely. And I mean, if there's ever any issues, escalate it. I'm not saying nurse them at home, ignore them and stuff like that. No, if there's ever any issues, we have to have a form of escalation process, that the doctor will be aware, and then they can say, "Okay, bring him or her in, or we will come home and look after them." But the palliative process and end of life process need to be dealt with, and people's choices needs to be met. It's not scary. It's not an omen. It's not a stigma to die at home. It's actually a beautiful thing to be home, in your home, surrounded by people you love, that goes through that journey with you. And to be fair, we need to pay more attention to the things that we go through, and doctors to be a bit more patient, explain things that are happening to their patient. Don't just write prescription for people to go away without telling them, because if they don't understand, they don't even understand why they're taking the different medication. They don't know what the medication is for. They don't understand all these things. And at the end of the day, it's their bodies. The days of the doctor knows best is gone. I'm not saying we know more than the doctor, no. But what I'm saying is incorporate the patient, incorporate the family into the whole holistic care of looking after somebody. After all, they've paid for these services. I know you're overwhelmed. I know you haven't got time, but it's better to do a good job with one person than to do 10 jobs without doing anything at all. So I'm pleading with the doctors who are listening today, who will defriend me after this, but it's said now. Please look after us.
Um, do you even think we know our rights as patients in Ghana? Do you think patients even know their rights? Like when they go to the hospital, because we have a lot of negligence going on. People die needlessly, and nobody is taking them, into account because We are not trying to compare, the Western world, to Ghana, but we have a lot of professionals coming here, and then they themselves confessing to the more practices actually going on there. So we're also just pleading. We have our mothers, aunties, uncles. We still have families back home.
Yeah.
And what really hurts, especially those of you, who are nurses over here, you are doing your best to look after people very, very well. And then you see your patients, your parents not being looked after well. And sometimes it really, it's not right.
No.
It's not right. It's not
No.
right. Let me say, when does end of life care begins?
So end of life care begins when your body is just saying, I can't do all of this anymore. And it's not responsive to any of the medications that we will give. So when that happens, we've got like three main stages that your body may go through. One of them is agitation, one of them is pain, and one of them is nausea and vomiting. Those are the three main symptoms that happens. It doesn't happen. It doesn't mean that when you have these symptoms, it means you are dying. No. So when you've come from that palliative stage and your body's just going down, 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 and stuff like that, then when you get to that kind of end of life, these are some of the things. Another thing is you find out that people cannot void as much as so they're not passing urine, they're constipating a lot. And yeah, so those are some of the things that we would actively treat and actively support you with. So that's one thing that I know for sure. We would not leave anybody in pain. It's wrong. If somebody ever said I'm in pain, it breaks me, because you never want somebody who is on this journey to you don't want them having any additional things that you could help them with. So we will treat this pain with some morphine. If we're giving you morphine a lot in a day, we've come to give you 3 or 4 injections in a day to treat you for your pain, then we would consider a syringe driver. So a syringe driver is a little machine that helps release the morphine slowly into your subcutaneous to make sure that you stay on top of the pain, because we don't want to leave you in pain when you're going through this scary moment. Yeah, I remember when my uncle, you would ring him and he will be screaming and he will beg that he is in pain. And then I asked, why have the doctors not, what is he taking for pain? And they will say paracetamol. And I says, which doctor is prescribing this paracetamol? Because I will write about this doctor in the newspapers and publish him or her for prescribing paracetamol for this patient who has this pain that I know there are other things, gabapentin, pregabalin, things like that, tramadol. And then once I said I'll write about this doctor, then I was told that, oh, he's been prescribed tramadol. But we've bought him a blood tonic. Yeah. So why would you give somebody blood tonic when you're in pain? And why would you not give them their tramadol? And the answer I got was, oh, when he takes the tramadol, he sleeps. Okay. So when he's awake, what is he doing? Would you rather have this person awake and screaming he is in pain, or give him his tramadol for him to rest peacefully? And then when he actually died, people were writing, rest in peace. How is that possible? How? So these are the little things that sometimes the doctors are doing their best, but patient comes home and certain people take the power into their hands and treat people this way just because they can, or just because you're in their care. Don't do that. It's wrong. People are vulnerable and they can't help themselves at that point of time. If you can help them, let somebody else do that. You shouldn't ever leave anybody in pain. No. So that's one thing that we need to keep on top of. When I came to Ghana, around 2023, when I was asking my doctors around trying to see if we can get some control drugs, because we wanted to set up a palliative outreach. So there's a whole legislation and stuff like that around it. But I hope one day we will get over it and then work as well or as effective as we have here in the UK. The other thing that we will look out for is vomiting and nausea as well. So around that time, people tend to vomit a lot. And then cyclazine is something that we will give, or levomaprimazine is another drug that we will give. If I have given 2 or 3 times during the day, then I would consider putting it in a syringe driver so that you don't have that feeling, because sometimes vomiting can be painful as well, and they could aspirate. Even though they are dying, I don't want them aspirate and dying from that. So we will treat that with some levo or some cyclazine. Another thing is agitation. People get scared, people hallucinate, they get disturbed, they behave in an unusual way, they want to climb out of bed, they don't want to be in bed, um, they're screaming and things like that. It's all part of the process as well. We will give madazolam to treat that, to relax them a little bit, but in Ghana, try that, if a patient was hallucinating or shouting or trying to climb out of bed, we will get the carpenter to make a bigger bed, so that we can lock them in instead of getting a sitter to sit with them and providing a human approach to things. We would rather provide a mechanical approach to things. So we need to change our whole outlook of the way we treat people when they are vulnerable.
So are you saying there's no palliative care at all in Ghana? There's nothing like that.
I have lost 2 people that I'm very close with, and I was privileged to be there till the end, and I didn't see that.
Oh, that's
No.
shocking.
Yeah.
Okay, so okay. Now let's get to UK here now. I think that will be a bit easier for us.
Yeah.
How come there's insufficient access to palliative care?
UK is doing well. They've got the district nurses that sometimes they can outsource it to agencies like myself. So we can go out and look after people who are dying in their palliative state and end of life. And like I said, within the UK, if you were end of life or palliative and you call, we've got 1 hour window to get to you. And if that doesn't happen, your family has got the right to complain and report it, and it will be looked into. So if I was on a night duty as a district nurse and I had a case to go to, say like a block catheter or a wound care, and I get to the patient house and I get in, settle, and I have a call that somebody is in pain, I will leave that patient and go and look after the patient in pain and come back. So although I'm already in your house, although I've opened my case ready to look after you, once I get a call about palliative patient, I'll be leaving you to go to my palliative patient, because like I said, you can tell us where we went wrong and how we can improve our services, but the person dying will never be able to tell me how I did, or how to improve my service. So I think within the UK, palliative care is like, we're doing a good job as district nurses.
Great. So, how do people find out about end of life care services in their area? Or
So they've got the ICB and they've got the
ICB?
hospitals as well. So yeah, so they've got say if you needed to be discharged from the hospital, if you decide to do this at home and you needed to be discharged from the hospital, they will now fast track you and let your social workers know, and let anybody who is involved, your local district nurses will know. So the district nurses have got different teams. So based on your address, so the team there will be notified that you're coming home today and you are palliative care and on end of life, and then they will get to you. So they will come to your house, they will bring a box of preemptives that will have some morphine, midazolam, cyclazine, and every medication that you need. So we call it just in case medication. Some people may never have to use it, and others do. So when that happens, we come, we set up, and then we look after you that way. So if you need us, all you have to do is kind of ring. They will leave the district nurses numbers with you. So all you need is call, and it's 24/7. So it's a good service.
Great. So, what actually goes into the planning and implementing also palliative care services? What goes into it?
So if we have a new palliative care patient, we'll be looking at the history of the patient. So what they had before, what they're dying from, and stuff like that. And somebody will go home, sit with them, talk with them, see what their expectations are. I once had a patient who had just come home and he wanted to watch some football match on Sky, but he didn't have Sky. So I wrote to Sky UK, and I told them my position and the person, and that they wanted Sky fixed. But I think once you call, it takes a few weeks. They send this, they send that, but this person hasn't got weeks. And somebody responded from Sky. I always say this, and I'm very thankful to them. They responded to my email, and within a day, they had come to set up for this patient. And he watched the TV and died New Year's Eve. So that was one thing that I was really proud of, and to be able to have the services when needed. So when we come, we will ask you the things that you expect. If it's things within our range, district nurses will always do their possible best to look after you and incorporate your family in the care. If it's things that like certain things, you just have to step outside the box and support the patient that way. Yeah, you just do it, because like I said, they won't come back to rate you, they won't come back to give you feedback. So you just have to do what's best.
Wonderful. So, how can patients get the best out of palliative care?
In UK, you don't have to do anything. In UK, I think district nurses, and the understanding is there. The job description, and as and it's all passion, it's wanting to do something for somebody. It's just the compassion that goes with it, and the commitment that, what, I'm glad I'm not the one going through this, but in the meantime, I will make it pleasant for you. I don't have the understanding of dying. I've never died before, so I don't know. But somebody in that position, I am going to be empathetic about it. Mind you, sometimes the people lying in that bed, they also feel bad for their family. They're thinking about them more than they're thinking about themselves. So you need to incorporate the family in the care, make them feel like they're part of the care, or the care is also about them. You can't just go there and look after the patient and walk away. If you go there and the wife is crying or something like that, you will look after the wife as well. Not giving medication, but at least you will sit down with them. I mean, I've been on out of hours when people have called, patient is in pain. You get there, patient is asleep, and you could tell that the wife or husband is really distressed. You just don't leave. You stay with them. If you've got capacity, you stay with them, and you reassure them, because at the end of the day, they are the ones taking care of this patient before you turn up. So you need to reassure them.
Great. So what goes into the care plan? I mean, if you can just take us through.
Okay, so some of the care plan that I will make will be for pain, will be for agitation, excessive mucus, constipation, urine, personal hygiene, mouth care, wound care to prevent any pressure sores, fluid and nutritional care. I'd like to know what you're eating and what you're not eating, and how your fluid intake is during the day. I would do a routine reposition care plan for people as well, to make sure that you're being supported to turn around, especially if you're not mobile, so that you don't develop any bed sores, because that's the last thing you would want. Ensuring comfort is another thing that I'll be looking after. So what makes you comfortable? What makes you comfortable is not necessarily what will make me comfortable. So I need to have that conversation with you, and you will tell me what makes you comfortable, and I will ensure that I do a care plan to support you so that you're comfortable during this period of time. I would also put in a hospital avoidance care plan that we look after you at home. And if anything we can do for you at home will be done, except it's really, really important that you need to go into hospital. We would not be putting you through that traumatic experience of going into hospitals. If we need to call out the GP to come and see you, that's what we'll do. So we will talk about hospital avoidance. And then I would also be looking at maintaining dignity and confidentiality. Sometimes when people are dying, they like to share things with you, things that are confidence, things that are personal. You're not going to listen, and then you go to the office and a handover, you talk about it and laugh about it as if it means nothing. It means something to them. So if they've shared it with me, it means something to me, unless it's something that I need to safeguard, something that I need to report to make sure that you're getting quality care, or something that compromise their care. I need to keep confidentiality. The most important care plan that I will do, it will be a person-centered care plan. I put the patient in the middle and draw arrows and make sure that everything about this patient is looked after: spirituality, family, health, everything about this patient, everything that matters to this patient. Sometimes some people is their cat. I don't like cats, but I mean, if you're dying and your cat is important to you, whatever you want me to do about that, will be put into consideration. But the fact that I don't like cats doesn't mean I'm going to ignore that bit. So everything that is personal to this person, everything that means something to this person, everything that will make this person relax, this person to journey on peacefully, I'll be looking at it. So I'll create a person-centered care that incorporates everything that this person wants or would like to see happen for his care, including the person himself or herself.
Great. So, what are some of the advantages of palliative care?
Is that you get, like I said, that's the catch 22, because nobody that has had end of life had ever come back to say, you know what, my palliative and end of life care was top notch. You didn't do this well, you didn't do that well. So based on the small evidence that we have from ourselves, colleagues and stuff like that, some of the positive thing is you recognize it, you talk about it, you talk about advanced care plan, you nominate people to care for you. So this is my biggest challenge, and this is what's happening in Ghana. In Ghana, when you're sick, automatically your wife or your husband is the one that has right to speak to the doctor. That's if they're even lucky to have a doctor to talk to. No other person can talk about your medical records. Or so if your wife is not interested in your care, if your wife is not willing to listen to advice of other healthcare practitioners, then you are doomed. Because they will not make any informed decisions. They've not allowed themselves to be informed, to be able to give consent or even give permission for anything to happen. So they're there thinking and proposing things and agreeing to things that necessarily you wouldn't have chosen. So that's the danger of the whole thing, that apart from this wife who is not a medical person, or this husband who is not a medical person, is now making medical decisions. How scary is this? So we need to look into it and make some few changes. People need to nominate. And one thing also that I will really stress on, that when you leave here today from this, choose somebody who will be responsible for your care in the end. Please nominate somebody. It could be any nurse or any family member that you trust, that they will act in your best interest, that they will put you first, that they will do things that you would have wanted for yourself, that they will actually look after you. It's really, really important. I've known people, well, personal experience, where everything that matters to this person, he was stripped off in the end. In the end, he was stripped off of everything that mattered to him. So that was a very painful death to me. Whereas my mom, on the opposite side, she died with everybody around her. I was there. My son was there. We had two visitors that she hadn't seen for a while. They were also there. And when we came to see her again, she had passed away. What a beautiful way to go. And then on the other side, somebody's being taken to the hospital every 5 minutes. So visitors cannot come and see you because you're sick. We don't want anybody to know that you're sick. How is that hurting you? That the person you know, I just can't get the word out. If your spouse is sick and you want to keep it a secret, how is it beneficial to you? Do you not think that this person will like his own people around? If he's being part of a society, do you not think at this time he would like the people to come around him? Most of the time, this is the time people share deep things. So why are you robbing him of that before he leaves this earth? This will be the last time you probably see him. I don't know, like we talk about God and after whatever, but this is reality. This is the last time I'm going to see this person. Why are you robbing me of this opportunity? Depending on where they go. If I go to heaven and they are going to hell, then that means I'll never see them again. So at this time that I have with him, why are you robbing me of this opportunity? Let's not be too cruel. Let's not be too stuck in our ways. And all the really, I don't even want to go into that, all the religious stuff and things like that. Let's not be too stuck in our way. Let's allow people to go peacefully. If somebody had killed them and that's how they were going to go because somebody had bewitched them, they're going anyway. So let them make peace. Let people come around them. Let them say their goodbyes because it helps in the grieving process as well. When you've had the opportunity to sit with somebody not long before they die, if I knew my mom was going to die that afternoon, I wouldn't have gone to see the visitors. I would have asked the visitors to stay there and I'll stay in the room with her because that's important to me. So in all these things, we have to take that person into consideration. The things that matters to the person is the things that you're actually looking at. Don't be too stuck in your ways in like, okay, you know what? I don't want people to think this of me. I don't want to do this. I don't want to do that. It's all about that person. Make it their experience. And I think, I don't see this change happening. I don't see this conversation going very far or people listening. I think we're going to do what we know best, but I'm hoping that the next generation that are coming, we would have a lot of impact on them. They will have the exposure, they will have the understanding, they will have the empathy to deal with people who are in this state and make sure that my exit is not as painful. It's not as cruel that somebody's not making silly decisions who have no knowledge or whatever about my care, that I'm putting people in place. I'm making sure that I've outlined exactly how I want things to be for me and until God calls me. So, yeah.
I like the word empathy. I think that's what we lack as a like as a people, and I know you are looking to just recruit and also to train people in your area of specialty. If you can, just talk to the audience about your company and yeah.
Yeah. So in 2019, I set up a little company named after my mom called Brepo Limited. So it's BREP and then LTD. So that's Brepo Limited. So with Brepo Limited, we set up to do domiciliary care. So we'll be going to people's homes to look after them in their own homes. And some of our services include palliative care. That's one of our biggest areas. We also are looking into, sorry. So palliative care, comfort care, live-in carers, transport, theatre aftercare. So if you've had surgery and you need clips removed, sutures removed, we will look after you as well and do all that nursing aspect. We also do community nursing. So if somebody's having a a permanent cathetering and needs changing every 3 months, we will come and do that because we've got some nurses with us as well. So we look after theater people who have recovered from surgery and things like that. So our company is Brepo Limited and it's all on Facebook.
Okay, so if you're actually looking for a job in the health sector, I would just recommend, also Bripol Limited. Here to
Yes,
you.
Brepo
And
Limited.
Effe is the boss, and you can tell that she's got a vast amount of experience, and you can tell that she's a no nonsense. Yeah. So that's. I mean, it's open to all of us. Let us support her business, and let us also learn how to look after our own as well. Do you think we have palliative nurses in Ghana, or even
I've,
doctors? I don't know.
Yes. So whilst I was on the verge of creating a palliative pathway, I came across a lovely doctor called Barbara. She's a St. Rose's girl, and I added her to our group of doctors. So she was a pediatric palliative doctor. That's a very scary thing. So she did it for kids. At the time that I met her, I'm still in contact with Barbara, and because she deals with kids, I can't deal with kids, So she deals with kids going through this, and that means dealing with the parents as well.
Yeah.
So I just do adult, and she does pediatrics. So hopefully one day we'll be able to team up and have a proper pathway in Ghana where we would incorporate our other doctors. To support us in prescription administration and then locating our patient and looking after them in that form. So yes, we've got a palliative doctor, but she's a pediatrician.
Wow.
Yeah.
I've never met a nurse that is so passionate about her job like you before.
Oh, thank you.
You've got a very, very good heart. So into what God has called you to do. And for you, I'll say that your nurse is a calling. It's not just something that you just chance upon. And I just hope that anybody that takes on nursing, just ask yourself: do you have the empathy? Do you have the heart? Do you have the patience to look after a patient? If not, please look for another profession. If not, please, yeah. And Effe, like your final words here before you go. I mean, or if there's any area that you want, you want to educate us on here before you go. Yeah.
It will still come back to empathy. It will come back to person-centered care. It will come back to individualized care. Like I said, the only person that matters here is the person that is dying.
Yeah.
If whatever they want does not align with what you would do or you want, please, it's their journey, not yours. If you are dying, you can make those changes to yourself. But if it is not you who is dying, the person that is dying, the things that matters to the person, do not rob them. Do not rob them of anything. And then at the end of the day, you will put rest in peace. No, they will not be resting in peace. I hope they come for you. And that's it, bottom line. So make it personal. If you decide, if you don't want to look after that person, step aside. It's quite simple.
Okay.
Step aside. Let others who will do it and do it well have that, because sometimes, in as much as that, I don't want to be too harsh, but if you are looking after somebody that is dying, especially if it's a husband or a wife, you've loved this person, you have children with this person, and then you see them this way, it could be quite challenging and you may not know how to behave. So if people are talking and telling you and advising you that you're being a bit too harsh, you're not doing the right thing, please listen. We understand that you're grieving. We understand that you don't have the whole knowledge on how to look after the person. That's why people like me are there. If you get in touch with us, we will do care plans. If you need a sitting or carers to come in, we will support. But do not let that kind of religious mindset burden you to the extent that you lose out and the person that you're looking after, you actually end up punishing them. It's not right.
Do you know what? I'm so proud of you that you have the mindset of wanting to set up something to help, people in the back home. And if Dr. Barbara is watching us tonight, please hold Effe dear. You know, I just hope that you don't lose touch, and maybe one day you team up and train a lot of people. That will help. Um, I don't know, help families, patients actually transition into their final journeys peacefully.
Yeah.
And I mean, if someone is in Ghana, like if someone in Ghana, sorry, wants to reach out to you for care plans and stuff like that, would you be able to help? Or I mean, it would have to be in strictly in the hospital setting. I mean, like, what is it like if somebody wants to, just employ your services?
So with COVID coming, we've all learned how to do things virtually. So
Right.
if I ever took up a patient in Ghana, I go to Ghana twice a year, so that's a plus. I will go and see them personally. But from talking to them, maybe doing a Zoom meeting or WhatsApp video calls, I'll be able to assess my patient and do a care plan. In the past, some of my friends have supported them by doing manual handling and moving. Position change for their parents so that they're not stuck in one place and they understand why they need to change positions every hour, especially if the patient is bedbound. So these are things that we could do. And then you'll have the evidence. After I've done the care plan, I'll send you a template. And then whoever is looking after the patient could would sign the template every hour or every 2 hours as per the person's needs, and then we'll look at it from that point of view. So if I have a care plan for pressure area, the patient shouldn't have pressure area then. If I do a care plan for you and the patient end up having pressure area source, then whoever is looking after the patient, I'll be questioning you because based on what we've developed, the person shouldn't. If I do a nutritional care plan for you and you follow it and the patient is deteriorating, it means the body is just deteriorating and things like that. So if you want a hospital avoidance, I've got a few doctors on standby who are very nice. A little attitude problem, but you're okay.
No.
And we can access them as well. Phone call, they could come and see the patient for you if you are in the Accra vicinity. So I've got, I think, four doctors at the moment, and Barbara is the fifth one because she's pediatric. So I always count it separate. But at the moment, we've got four and Barbara, so five, and we team up and we will do all of this for you as well. So yeah, so it's a nursing consultancy as well.
Wow. Wow. I am so proud of you, Effe.
Thank
Uh,
you.
yes. You know, I know we've come to the end of the discussion, but I think I mean something just. What if you're dealing with patients who are not, mentally, capable of making decisions for themselves? What do you do for such people?
So you always have best interest care plan. So if say a patient has dementia and I come in touch with such a patient
Hmm.
and the doctor is telling me, oh, she's not eating her favorite food. Of course, she's got dementia. She's not going to remember this is her favorite food.
Yeah.
All we need to do is give her something nutritious. So we will do a care plan. We will see the things that she's liking now, because with dementia, you could never tell. So if she likes something, we have to do all these powder form things and put it in whatever she's eating every morning to make sure she's getting maximum nutrition. So yes, with people with dementia, yes, it's hard, but it's doable. We just have to work with you. You need to understand. And then if your father or mother just forget who you are, that is hard on you.
Yeah.
So I don't expect you to be kind of reasonable with us, but if you work with us, we will work with you to make sure that we give in a holistic care to the patient, because at the end of the day, like I said, it's not you, it's the patient that is my priority.
Oh, okay. Just before we go, I think I've got a question here. It's not over there, so I'll try and read it out. Someone wants to know if you work with, solicitors, attorneys, and other, like other bodies. Do you work with such people? I mean, let's say if somebody wants to help you, like with their wills and stuff like that, do you do
Oh
such?
no, no, no.
Oh,
I
okay.
only do advanced care plan. So
Okay.
I don't do people's will. No. So that's one beautiful thing about it, that you can nominate somebody to look after your health.
Okay.
That's all, your health, because
Just help.
all of it is not together. So if I've got an accountant, they may not know anything about my health. In the end, if I needed a tracheostomy, say I say, okay, if something ever happens to me and I'm not eating well, I do not want a peg feed. I would rather go peacefully than have a peg feed. It's something I need to write down, because doctors will put in a peg for me, because for doctors, it's maintaining life. That is one of the priorities. But if I don't want peg feeding and tracheostomy, especially with people with motor neuron disease, they have their mental faculties all right, but they can't communicate.
You can
A
communicate.
very, very painful degenerating of the body. It's a horrible, horrible disease. So if they have put things in place like that, they need to nominate somebody who will speak for them. Mind you, your next of kin may not have that knowledge. So if you have somebody who is your next of kin, who the hospital will call, it doesn't necessarily mean they are the ones who are going to make clinical decisions. So you could have somebody who is doing clinical decisions for you, and you can put it when you go to the hospitals. You can update your records that this is my next of kin, but if you need to make any medical decisions when I'm not in the position to do that, this is the person I want you to contact.
Okay.
And then you can update things like that.
Wonderful. We
Yeah.
have a lot of comments coming in. I wish I could read all the comments, but I think I've seen a lot of reports to hang people, actually waiting for you tonight. And you could tell that, what, your girl has done justice to tonight's discussion. And we are so proud of you. We are
Thank
super
you.
proud of you, Effe. And I just wish you well. And
Thank you so much.
anyone that needs Effe's services, please don't hesitate to contact her on Facebook, unless when you have a number that you want to put across. And
So the number is, just 1 second. So our number is 078 795
795
14348.
14358.
No, 348.
348. Okay, so
Yeah,
your
so
number
078
8.
79 514 348.
Okay.
Yeah, and
All
our
right.
website is www.brepo.co.uk.
Okay.
And if you want to email us as well, it's info.brepo.co.uk. Please email us.
Okay. I will just put the link, all the addresses that you've sent to me.
Okay.
I'll just put it on the video. I mean, right after the discussion. So
Okay,
the
thank
number
you.
is, if anyone wants to, reach out to you, the number
Yeah,
is, 078
yeah,
795
yeah.
14348.
Yes.
078 795 14348. So if you're
Yeah.
calling, outside UK, it's zero.
0044.
Sorry, it's +44 78 795 14348
Yeah,
+44 78 3. Sorry, 795 14348.
yeah,
And it's www.breport.co.uk,
yeah,
and also info at breport.co.uk.
yeah.
Am I right? Okay,
Yes.
that's fine. Yeah, that's fine.
Thank you.
Thank you so much. Oh, thank
Thank
you.
you.
I've got I've got my brothers online. Thank you so much. I've seen Pastor Gesna Adjei, Apostle John Opoku. I've seen Ekuyakwa. Ekuyakwa wants to know, do you have a rep in Ghana?
Because I come to Ghana that much,
Okay.
I'm in Ghana most of the time. If you email me, I'll give my personal email as well. So it's effe.adjei, ADJEI at brepo.co.uk. And if I'm coming to Ghana, I'll let you know, and then we can make some arrangements if you want me to see somebody one-to-one. But we can always do WhatsApp video calls, and if you need care plans doing, by all means, we'll do that.
Yeah. Let's read maybe one or two. I'll say your comments. I've seen Emmanuel Nyako. He goes, "Hello, Auntie Effe. Fair play to you. You have always made us proud, and all we can say is keep up your great stuff in bringing the family facelift." Oh, that's
Nice.
nice. And I've got John Poku, Apostle John Poku, also saying, "God bless you guys."
Thank you.
For making time to discuss about this vital issues. And I've got my own brother, Pastor Adjei, also saying, "God bless you," and I've no so again. And and I've got, the comments keep, it keeps coming. And I can't read all the comments, guys. Thank you, but thank you so much for your support. And let's make sure that we have the heart to look after, anyone in our care. The empathy, the patience. Let's supply some sensitivity. When we have patients in our care, nobody wants to fall sick.
No.
Nobody wants to die. But that is part of life. It's part of life. So if you chance on, looking after anyone that is not well, please do so with a good heart. And also with a clean conscience as well. Because maybe one day it might be your turn.
Of course.
It might be your turn. Because we all don't have answers to life.
No.
Nobody wants to be in that, situation. I've had several, surgeries, and hospital is not a pleasant place to be.
No.
Trust me. So we want our patients also to be looked after well. And, let us make those few moments, those few months left a bit more, memorable, treasurable as well. And just ask yourself, how would you want to be treated? I think that will help you, look after somebody well. How would you want to be treated? Especially in your last few, months or days or weeks. How would you want to be, looked after? Tonight we've been educated on palliative, on end of life, matters. I hope you've all learned something. And let us be the doer of the words and not just the listeners, just to deceive ourselves. On that note, I say, Effe, thank you so much for your time.
Thank you, Nana.
Thank you for availing yourself, to educate, the world, and especially Africa tonight. And, we are so, super proud of you. And I know, your parents will be so proud of you. And anybody that has actually engaged, your senior services. So thank you and good chance.
Thank you so much. Thank you. It was a pleasure for giving me this opportunity. Thank you very much.
You're welcome. You're welcome anytime. So you take care. And all of you have a best week as well. Bye-bye.
Okay, bye. Bye.
Bye-bye.